Thank you. I'm Maria Pacheco. I work with Chattanooga Foot and Ankle Clinic. I'm a solo practitioner in Hickson. Currently, I used to work part of a large group, but now I'm kind of seeing patients on a solo basis to be able to give more of that kind of familial care, being able to accept patients on a same-day basis like you were talking about, just because it is that essential to get patient care, especially with lower extremity diabetes issues being so frequent and so kind of rampant in Tennessee. Well, my topic is how podiatrists can identify and establish potential problems in the lower extremity associated with peripheral arterial disease. So just a little bit of a peripheral arterial disease. I know we've all touched base on this a little bit, but it is a long-term condition. It's characterized by atherosclerotic plaques within the lower extremity vessels. It is gaining prevalence, ranging anywhere from 12 to 20% globally. And in patients over 60s, which is a large part of our population, we're seeing it in about 20% and increasing. The most severe form being critical limb ischemia. This is characterized by ischemic gangrene, ulcerations, and rest pain. An estimated 40% of these patients, unfortunately, once they present with critical limb ischemia, will undergo a lower extremity amputation without revascularization. So it's essential for us to be able to evaluate, early diagnose these patients prior to getting to those situations. So some people have touched base on some of the risk factors. A lot of our patients, they do come in either finding us on Google or from primary care referrals just for foot pain. So it's important for us to be able to identify what these foot pains are being caused by and what risk factors can be resulting in these types of foot pain. So as a podiatrist, I always like to educate my patients on proper foot care, advance on diets, nutrition, exercising regularly, and of course, smoking cessation. This is effective in reducing approximately 60% of amputations. Modifiable risk factors are going to include smoking because basically heavy smokers are 4 times more likely to develop intermittent claudication versus patients with PAD without smoking abuse. So it's important for all of us as healthcare providers to kind of advise our patients on a visit basis on smoking cessation. Diabetes, hyperlipidemia, and hypertension, this is something that we need to work closely with our primary care referrals, with our endocrinologists to make sure that these patients are being medically managed appropriately. Most of our patients will come in with a list of about 20 medications. You ask them why they're taking those medications, half of them won't tell you why. So if they don't know why they're taking these medications, they're not going to take them. So it's important for us as specialists, as primary care doctors, to be able to educate them because it's not common knowledge for everyone. So just a little bit of the effects of smoking. It is the primary cause of coronary artery disease. More than likely, you are going to coagulate blood at a rapid rate, clotting the vessels, affecting the cells in the lining of the arteries, and of course, increasing your triglycerides. Early diagnosis, for us, when we typically see lower extremity pain, you do want to go through a very thorough physical exam. Basically, if you do routine foot screening on these diabetic referrals at-risk patients, you can actually prevent amputations by approximately 90%. When we do our examinations, it's routine, or it should be routine for us to be able to assess lower extremity vascularity by just feeling the pulses, a very simple examination. But in my office, we do routine Dopplers just to make sure, because a lot of these patients will either have a lot of local edema, so we won't be able to palpate these. So being able to assess vascularity is a primary screening tool. When we do these examinations, other things other than assessing just pedal pulses is looking at callus patterns. So a lot of our referrals are, I'm sending you over for calluses. Well, calluses actually kind of tell us a big picture. They tell us where we're going to have the highest peak plantar pressures. And these peak plantar pressures increase the risk for preulcerative lesions. So these calluses that we're trimming, it's not just for the sake of trimming. We're actually trying to prevent these from becoming ulcerations down the line. We're educating patients on offloading them. We're getting patients into diabetic shoes to make sure that we offload these areas to prevent ulcerations that could potentially become life-threatening amputations. We do vibratory testing sensation, as this has been known to be statistically important in preventing or at least identifying areas of preulcerative lesions. And the same thing with monofilament testing. This is something routinely done in our diabetic foot screening. A monofilament test has been known to be 66% sensitive, but 91% specific in identifying areas with potential neuropathy that can become preulcerative lesions as well. So we really want to make sure that as podiatrists, we are seeing these people as a full picture, but really focusing on those lower extremity examinations. So a couple of the signs and symptoms we're typically looking for here. Obviously, the patient will say, well, not all of them, some of them are neuropathic, but pain in the legs with physical activity, rest pain, pain that can happen in the buttocks, in the hip, in the thigh, and calf. So we really can't ignore that by just focusing on the foot and ankle. As far as manual muscle testing, this is something I do on every patient. We want to identify any muscle atrophy, any muscle weakness, because these are very key indicators for peripheral arterial disease as well. Skin that is cool to touch, numbness, or unfortunately, by the time some of these patients get to us, they already have either preulcerative lesions or ulcerations to the foot and leg. In our diabetic population, our neuropathic population, we really want to make sure that we don't just assess for pain, right? Because a lot of these people are neuropathic. They're not going to tell us they have pain. So we really have to have a high index of suspicion and look at the lower extremity as a whole. When we get these ulcer patients, we need to evaluate and understand where these ulcers could be potentially coming from. Yes, there are just purely ischemic ulcers, but these are very few. These are about 15%. Most of these will be a combination of neuroischemic ulcers, and that's about 45 to 50%, where we have a neuropathic component, usually identified with these preulcerative callus patterns, preulcerative lesions, that kind of thing, and then the ischemic component. So when you're taking an ulcer history, you want to make sure you identify not only the location, but the duration, the onset, what kind of activity this patient has been undergoing. Has this patient been hospitalized for this particular ulcer before? And if this patient is currently infected. Adequate wound care techniques. For me, one of the most important techniques is offloading. Offloading, basically, because of these being 45 to 50% neuroischemic, if you don't offload, no matter how good circulation you have, no matter how good your wound care technique is, if you're not getting these patients off their feet, they're not going to heal that pressure wound. So that's critical. And then, of course, managing infection. Unfortunately, some of these will end up in the acute setting and in the hospital, so we need to work pretty well with our infectious disease team as well to make sure that we're managing these infections, because loss of tissue, deviability of tissue, at that point there's not a whole lot we can do. We have to either IND these or amputate them, and that's kind of our goal to prevent that. So early identification of infection. A lot of my patients, as we know, they're going to be diabetic. They're not going to have a high leukocytotic response, right? So we need to make sure that we're actually asking them, what is their glucose level? Because a big a sign of persistent infection will be recalcitrant hyperglycemia. These patients' sugar levels, no matter how much we try to modify them, they will not drop. We can order routine CBCs, A1Cs, SED rates. All of this can be done as an outpatient. We don't have to wait for the patients to be in the hospital to order these examinations, and we don't have to refer them out and wait for a few weeks before they finally get seen to get these things ordered, because as we know, diabetic infections can go from 0 to 60 in a matter of a couple of days. So in my office, we do routine testing. We do the Dopplers, but I have a very low threshold for sending these patients either to vascular when I have a high index of suspicion, or I order my own outpatient studies before sending them for a referral, just to kind of have things done. But basically, ABIs are a primary screening tool. Don't be afraid to use ABIs or order them whenever you have that high level of suspicion, mainly because it's a good screening tool. Most of these patients have never had a vascular evaluation before, so why not? With our diabetic patients and our renal patients, we do know that ABIs, the accuracy of it is dropped. So adding a TBI or a PVR, it could be limb saving. So just a little bit about ABIs again, arterial duplex. These are just kind of little tidbits of what we can order as outpatient. this is kind of a busy slide, but it just gives us options on being able to order wave Dopplers, ABIs, TBIs, PVRs, transcutaneous oxygen pressures. All of these things can be done again as an outpatient, and then eventually referral to vascular so that they can do any further testing or intervention that they find necessary. So a little bit about how to read an ABI. Anything between 0.9 to 1.3 considered normal. With our diabetic or renal disease patients, anything over 1.3 shouldn't be considered, well, this is normal, right? No, we have to consider that there is vessel calcification, and these patients should have TBIs ordered as well or referred to vascular for further evaluation. So educating our patients. We tend to, as healthcare professionals, think that a lot of things are common sense, but they're not. If our patients don't know what is happening, they won't follow instructions. They won't understand that there's a correlation with cessation of smoking and how does that affect my arteries. So during our office visits, it's important to provide oral and written information. In my practice, everyone leaves with a folder with information on all their diagnosis, everything I talked about, because no matter how much they nod in the office, chances are they're going to leave, they're going to get asked, what did they tell you, and they won't know. So it's important to really educate this patient population on what they can do at home, because this does increase patient compliance. So talking to them about nutrition, which I feel is an often neglected tidbit of information for these patients, how to control their diabetes, monitoring their sugar levels, and taking their medications appropriately. I think as a podiatrist is extremely important, since sometimes we're the first physicians they're even seeing. And of course, it's a multidisciplinary approach, like Dr. Lazar brought up. We have to work closely with our primary care team, our endocrinology team, because these are the people front lines. You guys are medically managing these patients for diabetes, high glucose levels, for hypertension and hyperlipidemia. We work very well with our vascular colleagues, because we do need them to open up that arterial system to really get circulation flowing for us at an optimal level to be able to either salvage a wound or do as distal an amputation as possible. And then with our infectious disease team, making sure that we control infections. The more an infection is let run rampant, the more proximal an amputation that patient will undergo, the more soft tissue loss, and of course that would lead to increased mortality in this patient population. So in summary, just understanding a little bit about the basics of peripheral arterial disease, making sure that we're at least making an early diagnosis or have a high index of suspicion in this patient population, identifying these modifiable risk factors that we can help with the patients, or the patients can modify themselves at home by changing their lifestyles, utilizing these inexpensive vascular techniques, doing a thorough lower extremity examination, especially establishing a good vascular assessment, educating our patients to increase our patient compliance, and utilizing our colleagues and our teams outside of our own specialties. References. Thank you.
How we doing? All right. So last year when I came to give this talk, I feel like I pontificated and kept talking and talking and talking and talking, because sometimes you get on a roll, you get in the zone, and I had this long talk with all these slides, and which I don't think is what Dr. Lazar wanted me to do. So I purposely kept this one short and sweet, but I think to the point. And some of what I'm going to talk about, Dr. Pacheco did sort of point out, which I think is a good thing, because I think it's something that a lot of us think, we naturally think is trivial, but in the high-risk patient, in the CLI patient, in the diabetic neuropathic patient, it's actually a warning sign of bad things to come. And if we handle it when it's in its trivial, sort of benign state or stage, we can avoid going through a lot of heartache as practitioners, and I'll certainly avoid a lot of heartache for our patients. So And basically, just wound care is manageable, right? It's manageable. It's much more manageable when it's caught early, and early sometimes means even before the skin has broken down. And the scary statistics. We've all seen these. These are more current statistics. I was looking at some old lectures I gave, and I realized that my statistics are about 10 years old. And the sad thing is they were horrible then, and they're even more horrible now. Of the amount of patients that are diagnosed with diabetes, not obviously being at a CLI lecture, we're dealing with patients that are not only diabetic, we're dealing with patients that have peripheral arterial disease. You don't have to be diabetic to have peripheral arterial disease. You don't have to be diabetic to be neuropathic. So, but obviously the majority of our patients that we deal with from a wound care standpoint are neuropathic diabetics. And this one, it's an old statistic, it's an oldie but goodie, but this was from Robbins in the Journal of American Podiatric Medical Association. And this is 5-year mortality for certain conditions, not only CLI, neuropathic diabetic ulcers, but, as we could see, amputation, not only amputation, a neuropathic ulceration. We haven't lost any digits, we haven't undergone an amputation, we haven't undergone a incision and drainage or hospitalization. We have a diabetic ulcer. And that's your 5-year survival rate with a diabetic ulcer. It's pretty sobering that it's equivocal to many cancers, and even worse than some cancers. And all sorts of publications out there about 5-year mortality after a lower extremity amputation, and several different publications, and we can go through these one by one, but they all say the same thing, that 5-year mortality is greatly reduced, not only when there is a lower extremity amputation, but just a lower extremity ulceration. This is one of the first to really look into that, and 80% 5-year mortality rate following non-traumatic amputation in diabetes, and that's a pretty high one. And of course, 80% of lower extremity amputations are preceded by a foot ulcer. So the majority of lower extremity amputations are non-traumatic amputations. And risk factors. We all know these. We're all familiar with these, and certainly there's some overlap. Peripheral neuropathy, elevated blood glucose, looking at that A1C creeping above 7.5. Obviously foot deformities. Things that as a podiatrist I'm going to see in my office. Bunions, hammer toes, osseous prominences, Charcot foot. These are things. These prominences, these osseous prominences, are where we're going to see an ulceration. And of course, repetitive trauma. Walking is traumatic. Whether you're neuropathic or not, walking is trauma. And so ground reactive force. So what's the ground reactive force? That's, going back to high school or college physics. That's Newton's third law of motion. Your foot hits the ground is going to hit you back with the same amount of force that you hit the ground with. Shear forces. So not only are you hitting the ground, but you're also rotating your foot if you have some sort of foot deformity. So you're basically rubbing a hole in your foot like you would wear a hole in a sock. So we have a plethora of classifications. I finally am able to use the word plethora. I'm not quite sure what it means, but I thought it would fit in this discussion. And basically, we have all these different classification systems. And, doctors, we love our classification systems. Some more than others. I think neurologists are the king of classifications. But, obviously, they do serve a purpose. The Wagner classification, it's an oldie but goodie. And it's an oldie but goodie because it pretty much, it's based upon the depth. And I think the most interesting thing about the Wagner classification is obviously, a patient comes in, they got an ulcer to their foot. You can see the subcutaneous tissue. It's a grade 1 ulcer. You could probe the capsule. It's grade 2. Obviously now grade 3, we're hitting bone. We're looking at a surgical problem possibly. Grade 4, we're definitely removing part of the foot, and grade 5, the foot's got to go. But included in this list of ulcers, it's an ulcer classification, is Wagner grade 0. Now, the interesting thing about Wagner grade 0 is there's no wound, there's no boo-boo. The skin is not broken. There's no bleeding, there's no drainage, there's no infection, we don't need to give antibiotics, there's a callus. So what happens? Patient comes in, now, maybe the patient sees this and like, oh, it's just a callus. Or patient goes to a primary care physician, they're diabetic, and I think what's great is a lot of my patients come in, they say, well, my my PCP checked my foot, and they saw that I have a callus, and they sent me to you, which I think is phenomenal. So I say this to our GPs out there, is when you see a callus in a neuropathic patient or a high-risk patient, it's not a callus, it's an ulcer. Well, the skin's not broken. It's still an ulcer. We have to treat it like an ulcer. And so what do? Patient comes to my office, we do the examination, we check, right, the vascular status, we check the neurologic status, we go through the whole entire examination, we look at foot deformities, all that fun stuff, biomechanical evaluation. They have a callus. I take out a 10 blade, I trim the callus. I say, let's put you into some diabetic shoes. The exam takes 10 minutes, it's not that long. It seems very trivial. Now let's say hypothetically that didn't happen. The patient didn't come in. I didn't trim that callus on the bottom of their foot. I didn't trim that grade 0 ulcer. It's not a callus, it's a grade 0 ulcer. Well, that grade 0 ulcer is going to become a grade 1 ulcer, and the patient sometimes comes in the office with maybe the callus is still there covering this swollen area of inflamed and necrotic tissue, and you trim it down, and you get purulent drainage, and you got this wound that probes to the subcutis or deeper. But it all started with just a callus. What if that patient came in the office and it was just a callus, and all I had to do was just schneid this callus off with a 10 blade? Seems trivial, but it would have prevented what could possibly turn into a long-term wound care issue. Now we have an open wound. Now we have that 5-year mortality that's horrible. Now we possibly have lower extremity amputation. We have tissue stress if the patient has peripheral arterial disease. So when you see a callus, it's not just a callus in the high-risk patient. It is a grade 0 ulcer. And here's another classification system. This is a little bit more complex. I trained under a couple of guys who trained at University of Texas, San Antonio, and this is the one they made me use. But the reason why I brought this up is I don't want you to have to remember this whole thing. It's an interesting classification system because it includes not only the depth of the wound like Wagner does, but it also includes a little bit of the pathophysiology. Is there infection? Is there ischemia? Is there both? But we go to the top left corner, we go to, A0, pre-ulcerative lesion. So even other classification systems consider a callus an ulcer, and we need to consider a callus in a high-risk patient an ulcer. So when we're doing callus management, we're doing wound management. So, obviously, we know what classification this is. That's Wagner 4. It's a little too late. But, here's a patient comes in my office. He's had some previous amputations. He's got these multiple submetatarsal head lesions. Is this an ulcer or is this a callus? And as far as I'm concerned, that's an ulcer. Skin's not broken down. It's not open. We don't have to admit him. We don't have to do any antibiotics. I don't have to take a swab culture. I don't have to call Chris and say, can you see this guy in the next 5 minutes? I just need to trim these calluses and make sure he's still in prescription shoes. It seems trivial, but if I don't, guaranteed, next time he comes to my office, there's going to be 3 open wounds I'm going to be staring at. So even though they're not open, I still consider them an ulcer. It is a Wagner 0 ulcer. So ulcer or callus? Yes. Wagner 0. UTSA 0A, if you want to get fancy. And then, of course, the American Diabetes Association, they have their risk categories, and this would be a category 3, previous amputation. So based upon that system, I see this patient once a month based upon the American Diabetes Association risk category. So debridement of hyperkeratosis, trimming these keratotic lesions. You're a GP, you see a diabetic patient, maybe they've had a previous amputation, they've got calluses. I'll send you to the podiatrist. Let them just trim these calluses. It takes a few seconds to do. Obviously, offloading the lesions, that could be prescription diabetic shoes, that could be orthotics, that could be combination thereof. Callus care is ulcer care. Trimming a callus, I'm basically preventing a wound. These are ulcers according to Wagner, UTSA, etc. Most classification schemes that you're going to see are going to include a pre-ulcerative lesion as an ulcer. So Wagner 0 lesion, this is a cavovarus foot deformity, and interestingly enough, this was a Wagner 1 at one point. So apex of deformity at the plantar fifth metatarsal base, site of a previous Wagner 1 lesion. It's now a Wagner 0. So we would say this wound, some publications out there refer to this as this wound is still there, it's just in remission. UTSA 0A, not preulcerative lesion or epithelialized ulcer, we're going to call it an ulcer. Let's call it what it is. And so monthly foot checks, ADA risk category 3 because it was a previous ulcer. Surgical reconstruction, do I really need to reconstruct this foot? put this guy through that type of mortality and morbidity to go in there and do this huge cavo-varus reconstruction, big osteotomies, you know, risk of amputation as high as 50%. I think that's a little aggressive, but I can do prescription depth shoes and orthotic management, and I can encourage this patient to come in and see me on a regular basis to do foot checks. So I just, you know, a simple accommodative orthotic with, it's kind of hard to see, but we put a big valgus post, rear foot and forefoot valgus post, take advantage of some of the subtalar joint range of motion, push the foot over, takes stress off the lateral aspect of the foot, it reduces pressure on the lateral column, that's the lateral aspect of the foot, and it has to be custom molded to offload the deformity. And I see this guy once a month, we trim the callus, he doesn't have an open wound, he's doing fine, he's active. You know, so, okay, you know, we can't always catch them, right? We can't always catch them when they're callous. So somebody comes in with a Wagner 1 lesion, bottom of the heel, which is a terrible place to have an ulcer because it's very difficult to treat. But okay, debridement of the hyperkeratosis, swab cultures, gram stain, you know, empiric antibiotic based on the clinical judgment. Well, this guy, note the green hue around the periphery of the wound, so I'm going to put him on a fluoroquinolone, which, you know, interestingly enough, in a patient with a heel ulcer is a little bit of a risk because usually they have heel ulcers because there's some sort of loss of the Achilles tendon, so I'm going to weaken it even more. So I'm going to put him in a walking boot to offload the lesion and reduce stress in the Achilles tendon. Interestingly enough, just from a billing and coding standpoint, you can't put somebody in a cam walker just because they have an ulcer. But usually if somebody has a plantar calcaneal ulcer, that you're going to have what we call a calcaneal gait. We have equinus, where the foot doesn't go up as much as it should. Well, the opposite of equinus is calcaneus, where the foot goes up too much. Maybe they've had a previous Achilles tendon rupture. So that is a billable code for a walking boot, and that can help offload the lesion. Of course, there's other ways to offload a lesion. Submet 2 lesion, we could use, there's all different brands of these. This is called a peg assist shoe. It's just a multi-laminate insert where they have these little hexagonal pegs, and you can mark the lesion and pull these little pegs out, and then you cover that with like a thin piece of adhesive cardboard, flip it over, put it in there, put it in a surgical shoe, and you could offload an ulcer. How do we mark these lesions? Well, you grab some cheap lipstick and put it around that lesion, and there you go. And that is basically cheap lipstick that we have there. It allows us to mark the lesion, pull those little pegs out, and this guy's interesting. He's had digital amputation. It looks like a transmetatarsal amputation. It's not a transmetatarsal amputation. He's had multiple digital amputations. His metatarsal heads are still there, but he is starting to develop this submetatarsal head 2 lesion because he's had a previous partial first ray resection. We've taken out a portion of the first metatarsal, so now all the pressure is on the second metatarsal. So he probably should, at some point, be entertained to have a transmetatarsal amputation. And here's that American Diabetes Association risk assessment. And, you know, this is, you know, how often should I see this patient in my office? You know, they're diabetic, their A1C is 5.5, they have no problems, they're healthier than I am, which isn't much of a stretch. They need to be seen, you know, annually, biannually. They have digital hair, pedal pulses are fine. They have no neuropathic symptoms, you know, once or twice a year. But then all of us, you know, we start to get increasing symptomatology, loss of protective sensation plus a deformity. Maybe they have a bunion, maybe they have a hammer toe. Yeah, now we're looking at quarterly examinations. You know, all the way to the bottom, which is ADA category, risk category 3, those are patients who've had a previous ulcer or previous amputation. These are patients I see at least once a month. And one of the things I say to my patients is, I just want to stay one step ahead of the game. Okay, you've had an ulcer, you come in, we have this callus. If I trim this callus, we're not going to have an ulcer. But, and I'm telling that to my patient, but in my mind, that's not a callus, it's an ulcer. So this is, you know, the best way to manage ulcers in the early management of ulcers is to not get them, but at the same time, if a patient comes in your office and they have a hyperkeratosis underneath an osseous prominence, they're neuropathic, they have poor circulation, they have a combination of both. It's not just a callus, it's an ulcer. So when you are doing callus care, you're doing ulcer care, especially if that lesion is the site of a previous Wagner 1 or greater lesion. I tell my patients, I just want to stay one step ahead of the game. Let me see you. Take 5 minutes. We'll trim this callus. That way, we're not dealing with an ulcer. Don't come back and see me when the skin opens again, which I have a lot of patients do that. They disappear. They fall off the face of the earth. Well, doc, it was just a callus. I didn't think I needed to see you. And of course, they come in and it's a total blowout, and back to the OR we go, and now we're taking out more of their foot. Or we're just doing wound care for another 6 or 7 months, and they got to deal with daily dressing changes and all that other crap when all they have to do is come in the office and just get little callus debridement. So sometimes the trivial stuff is the stuff that prevents us from having to go through, the headache stuff. I know we all love doing INDs at 11 o'clock at night. I do. It's great. So going to this, what I said about remission earlier, this was an article in New England Journal by Armstrong et al., and I think Bolton was on this as well, and basically it states that a site of a previous ulceration is a site of an ulceration. That wound is in remission. The wound is still there. Just because the skin is not open does not mean we just ignore it, send the patient on our way. See you as needed. I don't have a diabetic patient that I PRN. I don't say I'll see you as needed. They have an expression, sometimes you marry your patients. You come to my office and you're diabetic and you have these issues, well, to death do us part. We're going down this road together for a long time. And that's okay, because that's what we need to do, because, 60% recurrence of ulcers in 3 years. Why? A lot of the times, it's just because that simple callus care. So early management means managing these things before the skin opens, because when you're managing that callus, you're managing an ulcer. So thank you for your kind attention.
Hi, my name is Dr. Sam Bazrafshan. I'm going to be speaking about the diabetic foot, complications leading to limb threat. All right. So, some unfortunate statistics. Diabetes is becoming an epidemic in this country and throughout the world, with 10.5% of Americans afflicted with diabetes. It's the foremost cause of amputation, renal failure, and blindness. Every 20 seconds, a limb is amputated somewhere in the world because of diabetes. Approximately 25% of diabetics will develop a foot ulcer in their lifetime. More than 50% of diabetic foot ulcers, if healed, will return within 3 years. And 86% of lower extremity amputations in patients with diabetes are preceded by a diabetic foot ulcer. Now, diabetic foot ulcers, and the diabetic foot is biologically compromised due to a couple of reasons. The peripheral neuropathy, peripheral arterial disease, existing foot traumas and deformities such as Charcot neuroarthropathy, partial foot amputations, and or biomechanical abnormalities. Diabetes is associated with numerous complications related to microvascular, macrovascular, and metabolic etiologies. These include cerebrovascular, cardiovascular, peripheral arterial disease, retinopathy, neuropathy, and nephropathy. Currently, cardiovascular complications are the most common cause of death in this patient population, with rates of heart disease and stroke 2 to 4 times greater among diabetic adults compared to non-diabetic adults, and accounting for 65% of the deaths in this patient population. Now, complications leading to limb threat. We'll discuss the 4 main ones: ulcerations, infections, vascular compromise, and Charcot arthropathy. Ulcerations. It's the most common single precursor to lower extremity amputations in the diabetic population, with peripheral neuropathy, foot deformities, vascular disease, poor diabetic control, visual loss, and advanced age associated with greater cause of diabetic foot ulcers. Let's discuss peripheral neuropathy. Peripheral sensory neuropathy is the primary factor leading to diabetic foot ulcerations in the face of unperceived trauma, repetitive trauma. 45 to 65% of ulcerations that present to our office are purely neuropathic. 45% have a neuropathic as well as a vascular component. Motor neuropathy results in muscle atrophy, and patients develop foot drop, hammer toes, prominent metatarsal heads, causing increased plantar peak pressures, which develop into calluses, which we'll discuss. Autonomic neuropathy results in dry skin, fissuring, and cracking, which is a portal of entry for bacteria and a greater cause of infection in this patient population. Common injury leading to ulcerations is moderate repetitive stress associated with walking and day-to-day activities in a setting of a neuropathic foot. These are manifested, like Dr. Solomon just mentioned, in callus formations. These calluses form underneath the metatarsal heads, and you can see here a simple callus turns into subcutaneous hemorrhage. That subcutaneous hemorrhage breaks down, the skin turns into an ulcer. That ulcer turns to infection and potentially osteomyelitis. Now, abnormal foot pressures are usually neuropathy-induced, but can also be due to abnormal biomechanics or congenital disorders or prior surgery. Foot muscle atrophy, again, leads to hammer toes, fat pad displacement or atrophy, increasing the peak plantar pressures to the forefoot. Decreased ankle range of motion causes, again, increased forefoot pressures, and this leads to primary or recurrent ulcerations. Glycosylation of the collagen and soft tissue structures, specifically the Achilles tendon, will limit motion to the ankle, subtalar joint, midfoot, or forefoot, again, increasing pressure, causing ulcer formation. Commonly in our office, we see bunions and hammer toes, but with a diabetic patient, these are usually associated with wounds to these prominent aspects of the foot, commonly from ill-fitting shoes or improper shoe gear. Again, very difficult to treat. Now, another cause of limb threat is vascular compromise. Now, rarely do we see ulcerations, foot ulcerations directly associated with vascular reasons alone, but once the ulcerations do develop, these are very difficult to treat, and it elevates the risk of amputation. Makes treatment of infections difficult because it's difficult to get the antibiotics to the source of infection and lack of oxygenation to those tissues. Early recognition and aggressive treatment with our vascular colleagues is essential for limb salvage. Infection. With an incidence of 36.5 per 1,000 persons a year, foot infections are amongst the most common lower extremity complications in the diabetic population, excluding neuropathy, and second only to foot ulcers in frequency. A major predisposing factor to diabetic foot infections is hyperglycemia, impaired immunologic response, neuropathy, and peripheral arterial disease. Our patients that are uncontrolled diabetics, they are immunocompromised and have an impaired response to any type of infection. Ischemia, again, we're unable to deliver the antibiotics to the source of the infection, commonly within the foot. Peripheral neuropathy allows for progression of this disease process as the disease process goes unrecognized. Charcot joint disease. This is a less common complication in the diabetic foot, but is very difficult to treat conservatively or surgically, with a high risk of failure with reconstructive efforts. Now, let's see if this is a laser pointer. Yeah, so the Achilles tendon, there's an overpull of the Achilles tendon, causes the foot to break down, and these patients are purely neuropathic. They have a normal vascular circulation, and the joints break down, causes prominent aspects of the foot. It becomes, in our office, it's almost like a bag of bones. There's breakdown of the joints. Surgically, we can offload them, or we can utilize surgical techniques to reconstruct their arch to create a tripod. But this is a very difficult patient population due to the foot being inherently unstable, and poor patient compliance. Now, amputations. Reported risk of lower extremity amputations in diabetic patients range from 2% to 16%, depending on the study design and the population studies. but the best predictor of an amputation is a previous amputation. The 5-year survival rate of amputations have been as low as 28 to 31%, and those who undergo diabetes-related amputations have a 40 to 50% chance of undergoing a contralateral amputation within 2 years. The extent of vascular impairment and destruction of tissues by infection are the ultimate factors that determine whether a limb is salvageable. This is a nice chart, basically summarizing the multiple pathways we've discussed that lead to lower extremity amputations. Now, surgery has a very important role in this prevention of limb threat and limiting mortality and morbidity. Unfortunately, in the hospital setting, we are usually in the reactive situation where these are emergent situations, and we have to perform incision and drainage and partial amputations in order to save the remaining portion of the foot or their life. In my hands, in my practice, I've tried to be more proactive in this patient population in response to an imminent, present, or previous ulceration, performing several procedures that I'll discuss. And it's nice to be proactive in this situation, as we can optimize the patient vascularly and make sure that give them the best chance to heal and prevent further wounds. So, elective surgery to prevent ulcerations or prophylaxis is a great option in select patients. Some of the procedures I perform are minor tendon tenotomies, tendon transfers, major tendon tenotomies, Achilles tendon lengthenings, gastrocnemius recessions, medial plantar band fasciotomies, percutaneous metatarsal osteotomies, and Charcot reconstruction. Very commonly, we see patients that present with ulcers, and due to a neuropathic foot type, they have calluses that break down to ulcers to the very distal aspect of the toes. Very difficult area to offload. So what we can do with this patient population, as long as they have somewhat of a flexible deformity, is simply aseptically prep their foot in office and utilize an 18-gauge needle, release the flexor tendon directly underneath the toe. It releases the deforming force. These wounds heal very quickly. Tendon transfers. It's a very useful tool in correction of the deforming forces of the lower extremity. This patient has what's called perineal overdrive. It's an unstable foot type where the peroneus longus overpulls the first metatarsal, causing a wound underneath the subfirst metatarsal head. What we can do is transfer the peroneus longus to the peroneus brevis tendon. It offloads this area internally, and it's a great procedure. Tendon transfers in general are great procedures as we can utilize them to basically strengthen a weakened tendon, reduce the power of a overpowered tendon, and or just biomechanically stabilize a foot. The downside to these tendon transfers are they have to be non-weight bearing postoperatively, so it's only for select patients. Now, with that same patient that cannot be non-weight bearing, we can actually perform tendon tenotomies, major tendon tenotomies, making a 1 centimeter incision behind the lateral malleolus. We find the peroneus longus tendon and tenotomize it, and again, offloads the site of the wound. These wounds heal fairly well. This patient actually had failed a previous gastrocnemius recession to decrease the peak pressures with routine wound care, and went forward and did a perineal tenotomy, healed it in a matter of weeks. Again, Achilles tendon and lengthenings and gastrocnemius recessions are very well documented in literature to decrease the peak forefoot pressures, and are great procedures as an adjunctive or a primary procedure in patients that have forefoot ulcerations. Here on the left, you can see, these are not the two same patients, but you can see the procedure. Basically, small percutaneous stab incisions. We're able to release the Achilles tendon, lengthen it, and it decreases the forefoot pressures. The patient here on the right had this wound, previous transmetatarsal amputation patient, and developed an ulcer when she presented, and we tried wound care modalities, total contact casting, all failed, continued ulceration, performed a tendo-Achilles lengthening, healed the wound in 3 months following that. I'm sorry, 6 weeks. Now, plantar great toe ulcers are very difficult to heal. Due to the increased thickness of the plantar fascia, again, due to glycosylation of these soft tissue structures, it limits the amount of dorsiflexion these toes have, so that this area gets an increased amount of pressure. They develop these calluses that turn into ulcers. The ulcers are very difficult to heal, and multiple conservative measures were attempted with this patient. But there's recent studies on medial plantar band fasciotomies where we simply anesthetize the foot in office and utilize, again, an 18-gauge needle, localize the medial band of the plantar fascia, release it, heal these wounds in a matter of weeks. This patient is an 80-year-old patient of mine that previously had a partial 4th and 5th ray amputation secondary to gangrene, diabetic peripheral arterial disease, was revascularized by our colleagues, presented back to my office 1 year later with this sub-third metatarsal ulcer. Now, we have several options here. We can go to transmetatarsal amputation, we can go proximal amputation, continued wound care, but previously with the partial 4th and 5th ray amputation, he took months to heal, utilizing hyperbaric oxygen, multiple wound care modalities, and didn't want to go through any major incision. So you can use a percutaneous burr and basically offload the site of the ulceration internally. As you can see here, we're basically severing the neck of the metatarsal and internally offloads these heals, this site. They're able to weight bear immediately, and they only have to heal a small stab incision. And this gentleman healed his wound, and again, at an expedited rate, and it beats amputation any day. In summary, there's multiple complications that lead to limb threat, but taking a multidisciplinary approach to diabetic foot disorders has proven to improve limb salvage rates. Although not all diabetic foot disorders are preventable, it is possible to effect a dramatic reduction in their incidence and morbidity through appropriate evidence-based management protocols. Thank you.
So just very curious from the audience if there's any questions. I think as Dr. Solomon and Dr. Pacheco go back up to the stage, it's just nice to see, you know, we all have very different perspectives of what we do every single day, and to get that perspective from some of our colleagues is so valuable. So one of the questions I have from the medical community, you know, what are the common things that are we failing to refer that you think we're missing? Please, if you just come up to the mic and just tell us what you think. Any other questions?
Yeah, go ahead.
Well, you know, like what I was talking about earlier in my discussion, and I know Dr. Bazrafshin and Dr. Pacheco highlighted it too, is nothing is too trivial. You know, once again, you see a callus on a neuropathic diabetic patient, you know, once again, let's treat this as an ulcer. You know, don't go ahead and send it to us, because that's already showing that patient's high risk. We can do callus debridement, callus care to prevent that from becoming an ulcer. But also, even if there isn't any evidence of callus, I mean, just your standard neuropathic diabetic, if they're complaining of pins and needles, tingling, we know there's neuropathic symptoms, that's a high-risk patient. It could be something as simple as us just putting them in a prescription depth shoe, just, you know, to do preventive medicine. So they don't have to come into your office with, you know, a pussed out ulcer, complaining of chills and night sweats, and now it's an emergent problem. Certainly, you know, those small signs that indicate that somebody is a high-risk patient. You know, if somebody comes in your office and you diagnose them with diabetes, one of the first things you're going to do is you're going to schedule them to see a nephrologist. You're going to schedule them to see an ophthalmologist. Well, you know, it's sort of the same thing with us. You know, there's unfortunately not a system, I think, that's spared from this disease. So, you know, we should be on that. I think that paradigm of professionals you refer to when you have a patient with diabetes and you're worried about what systems are going to be afflicted.
So just I'm clear, you want all the diabetics.
Every one of
single diabetic. You want to see the diabetics.
Well, no, but if a patient comes in your office and they're a high-risk neuropathic patient, right? If they have neuropathic symptoms, if you're concerned about their disease to the point that you're going to send them to an ophthalmologist to make sure that they don't have any retinal hemorrhages, or you want to send them to a nephrologist to make sure that there's no you know, loss of protein in kidney, you know, loss of kidney function. Well, it would be safe to assume that if those systems are being affected, then obviously the feet are going to be affected. It's the same thing if a patient comes to my office and they've got a hole in their foot from diabetes. I look at them and say, well, if this is what your foot looks like, think about what your kidneys, your heart, your eyes look like. So.
And I'm assuming then if it's a fairly normal foot, there's really no major compromise. You're saying, okay, look, I don't need to see you back for a wellness check really for about a year or something like that. Is that pretty routine how you think about it?
Well, I mean, that's going to be like that loss of protective sensation, or that risk category 0 on the American Diabetes Association. They come into your office, they have digital hair, they have bounding 2 out of 4 pulses, they don't have neuropathic symptoms, they can sense a Sens-Weinstein monofilament. Yeah, that's a biannual or annual visit. But, the patient that comes in and maybe they're complaining of, paresthesias, pins and needles tingling in their feet, or they're being referred to other services because there are symptoms there. If there's issues with the eyes, issues with the kidneys, issues with the cardiovascular system, chances are there's going to be some neuropathic symptoms, issues in the foot, and those are going to be the patients who are going to have loss of digital hair, maybe diminished pulses, certainly diminished sensation. Now we're seeing more of a quarterly visit patient, more of a high-risk patient. They don't have an open wound or anything, but it's somebody we want to see on a regular basis to make sure we're not seeing any signs of early onset, like Charcot arthropathy, like Dr. Bazrafshan talked about, or any of these other issues, and make sure that they're in the proper footwear, prescription footwear.
That's cool. Is there any other questions from the audience? No, I think we're kind of getting there. I have one question for you, Sam, just real quick. That percutaneous osteotomy, you basically leave the metatarsal head in place, and as they walk, it just kind of flattens out.
It finds its place. It offloads internally. So basically what we would do with offloading shoes, where we'd cut that area out so they're not feeling the pressure, you can internally offload that because it's just the prominent metatarsal head, and it just floats. It finds its place. They walk. They don't feel it, and they just have to heal a small stab incision the size of sticking an 18-gauge needle in someone's foot.
Yeah, that's pretty slick. All right, thank you, everybody. So this is going to conclude the morning session. We're going to go ahead and I think we'll be restarting around 12:30 for the afternoon session, but lunch is provided in the back. Again, I'd ask that the lines start right here so that you guys at least walk through the area of the people who supported this conference, and we'll reconvene at around 12:30. All right, thank you so much.